Let's begin our session with the recitation of Holy Quran.
بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم كلا إن الإنسان ليطغى أن رآه استغنى إن إلى ربك الرجعى أرأيت الذي ينهى عبدا إذا صلى أرأيت إن كان على الهدى أو أمر بالتقوى أرأيت إن كذب وتولى ألم يعلم بأن الله يرى كلا لئن لم ينته لنسفعا بالناصية ناصية كاذبة خاطئة فليدع ناديه سندع الزبانية كلا لا تطعه واسجد واقترب.
Good morning and welcome to the third day of 28th Annual International PSR Conference. My name is Kainat Amir.
And I am Haris bin Khalid.
And we are fourth year students from Central Park Medical College. Before we begin, we request you all to kindly switch off your mobile phones. Please remain seated and maintain the conference decorum. A Q&A session will follow the talks. However, due to time constraints, we'll not be taking questions directly at microphone. Instead, attendees are requested to obtain Q&A cards from ushers, write concise and relevant questions, and pass them on to the chairs via ushers. We thank you for your cooperation. We are delighted to have you all after 2 insightful and enriching days of learning, collaboration, and exchange of ideas. As we move into the final day of this remarkable event, today's session promises to continue the momentum, bringing forth cutting-edge discussions, practical workshops, and valuable clinical perspectives from leading experts in the field of rheumatology. Let's begin our today's event and make the most of this concluding chapter of our scientific journey together.
Our first session for today is Plenary Session on Osteoporosis, being kindly sponsored by CCL Pharma. Please join me in welcoming Professor Nighat Mir, Patron-in-Chief PSR 2025 and Chair ACF and Fellowship Program at Central Park Medical College and National Hospital. Next up we have Professor Arif Khan, Orthopedic Surgeon from Peshawar, and as our chairpersons for this session. We also welcome Dr. Saira Elaine Anwar Khan, Co-Convener PSR and Head of Rheumatology at Shalimar Hospital as the Co-Chair. May I now invite them to take their seats on the stage? So now, beginning with our first speaker, Dr. Sumapa Chaiamnuay, Associate Professor at Pramankootlo Hospital, Thailand. Her talk for today is titled as Interpretation of DEXA and its Pitfalls with Interactive Case-Based Scenarios. Everyone kindly please welcome Dr. Sumapa to the stage.
So good morning, everyone, and thank you for being here for such an early Sunday morning. And thank you, the PSR 2025 Organizing Committee, for having me here. Today, I have 20 minutes to do the interpretation, pitfall, and also the case-based scenario. So let's start it. So I will do a stepwise approach of when you receive a BMD result, how would you go over the interpretation, and also how you use this BMD or DEXA for the osteoporosis treatment monitoring. And I'll give you some case base during the presentation. And for DEXA, just for you, DEXA has no E, it's only D, X, and A. So what information we can get from the DEXA scan? So DEXA stands for the Dual Energy X-ray Absorptiometry. You can get the bone density, which they will usually report L1 to L4, and for the hip, for the total neck and femoral neck. And sometimes if you cannot interpret from the lumbar spine and also the hip, you can use the distal radius, but only in the people that you cannot use the previous two sites. And then you can get the trabecular bone score as well as the fracture, vertebral fracture assessment. So for the BMD or the DEXA interpretation, there are 3 steps to approach. First, you have to check the general information, which is very, very important, and I will show you in some pitfall case. Next is the positioning. You don't only look at the numbers, but you also have to look at the actual scan picture. And also, lastly, is the interpretation. So let's start from the first. This is the common DEXA printout. This is in Thailand. We have 2 brand machine. One is Hologic on your right side, and the GE Luna on your right side, on your left side. So in the DEXA scan, they will have a name and demographics, the institution where the DEXA is performed. Very important, you have to look here where you look at the machine, brand, and model, because different brand, different model have different measurement. So it will be best if you can get the DEXA scan to compare from the same machine and same model. And between Hologic and GE Luna, you really cannot compare the numbers from these 2, because in general, GE Luna have a bit higher BMD result, about 10% higher. So if you want to convert, really, like if your patients come from one hospital with this scan and come to follow up with you with another Hologic machine, for example, you need to go to these papers and do some conversion. So you try to calibrate the BMD between 2 machines. Next, here is the bone mineral density. It comes in the unit of gram per square centimeter. And the T-score is when you compare it with the normal population. Now, for the T-score, it's really important that you look at the reference. So in the ISCD, recommend to use the enhanced data. So the enhanced data is the US data. So people are bigger bone than Asian, like in Thailand. So ISCD recommend we all use the enhanced data for reference. And I will have some case to show you. Next is the positioning. For the spine positioning, you have to make sure, look at the picture, the spine is center, straight, not tilt. And you should see both iliac crest and also the ribs, the thoracic ribs. And the scan should include middle of L5 as well as T12, but the one that you will be measured is L1 to L4. And generally, the BMD will increase from L1 to L4. And if there's some discrepancy, more than minus 1.0 T-score, you should not, you should look for artifact, and maybe you should exclude one with artifact. So this is the correct vertebra labeling. So in the picture, you have to see that you have a ribs. When you count for the vertebra labeling, you should look from L5 and move upward. So for, and also look at the posterior elements. L1 to L3 is Y shape versus L4 is an H or flattened X shape. How to interpret? So you will exclude the vertebra that may have compression fracture or some degenerative change, or if there are more than 1.0 T-score difference, you should exclude one. In case of when you calculated, you use the T-score of the rest L vertebrae. So, but if you have less than 2, for example, the 3 is already degenerative or have compression fracture, you're only left with 1, you will not interpret. So you will go ahead and use other sites. This is a case of a 60-year-old woman. She have a distal radius fracture, and she was treated with denosumab for 3 years from a scan in this one in 2015. And this is a scan in 2018. And look, we see here the T-score is minus 2.5, and again here is minus 2.5. So after 3 years of denosumab, there's no improvement. What is a pitfall in this BMD scan? Okay, I give you 10 seconds. Okay, so here the brand is Hologic, and here the brand is actually GE Luna. So usually we don't compare the two different brand machine. Furthermore, when you look at this vertebra labeling, it's actually the first scan that have the wrong labeling. So if you look here, actually this is actually L5 and move forward, and L1 is actually on this vertebrae. So the yellowish color here is the correct labeling. So what happened is, when you do a scan, the L1 here is actually L2 here. So it's very important for you to look at the scan and count the label the vertebrae correctly. Okay, so another patient. This patient came in with a discrepancy between L1 and L3 T-score of only minus 0.3, but the femoral neck is minus 1.6 to minus 1.7. So why is so much discrepancy? First, this is the VFA vertebral fracture assessment. Can you see here? The aortic calcification. So when the DEXA machine measured the BMD, the way the radiation exposure comes, it comes like this in the AP view. So the calcium in the aorta will also count as the calcium in the lumbar spine. So it's falsely high. Furthermore, this patient has a lot of degenerative changes in her spine as well. So the lumbar spine BMD, the T-score is falsely high, and we should not use, we just skip it. We just use the femoral neck and hip BMD. Another example of the compression fracture. This patient has compression fracture here at L3. That's why the L3 is more dense. So when we'll calculate the T-score, then we only use L1, L2, and L4 in this case. Now let's move to hip. When we measure the neck, the femoral neck BMD or the total hip BMD, we use the non-dominant side. Make sure look at the picture and the femoral shaft is straight. Leg is internally rotated about 15 degrees, and how we measure that, we look at the lesser trochanter here. You can see a little bit of lesser trochanter. If it's too big, it's not enough internal rotation. And the scan should also include the ischium and the greater trochanter. This is why you cannot really compare the Hologic scan with the GE Lunar scan, because these two machines that measure when there's a femoral neck is different. So the femoral neck in the GE Luna is from the automated system. They will look for the narrowest and the thinnest bone. However, for Hologic, the way they measure the femoral neck box is from the greater trochanter, and they will measure, and the size of the box is also different. So especially for the hip, for the Hologic and GE Luna, they really measure the different things. One thing that you should remember is never use wards. The wards triangle for measurement, either for diagnosis or the monitoring. So how to interpret the hip BMD? First, to verify the bone edge and make sure that your area of interest is in the correct place. And you can use either total hip or femoral neck, whichever is lower, and do not use wards or trochanter BMD. This is a scan, and the only pitfall here is the too much abduction. The leg is too abduct, and the femoral shaft is not straight. This is the VFA that you don't have to have more radiation exposure, just one-time BMD, and they can have this, it's a software to analyze the compression fracture. And anything that you can see the AP or MP ratio less than 75 means that the patient might have compression fracture. Another information we can get from the DEXA is the trabecular bone score. So there's a lot of numbers here, but you don't have to look. You just use here the trabecular bone score. And the good thing about trabecular bone score is not affected by the compression fracture, is not affected by the degenerative change. So you still can use it even the patient have compression fracture. And the way you use it, you don't use the number alone, you don't use the number itself, you incorporate this number into the fracs and incorporate the TPS to the T-score. Next is how to monitor. As BMD, we always use it for the surrogate markers as the anti-fracture efficacy. And also now, with the goal-directed therapy, the BMD is very important to tell us whether we're reaching the goal for treatment or not. So for the monitoring, very important that you make sure that you measure the same thing, the same area of interest, positioning, machine, as well as the especially if you can give the same technician, that will be good. And compare the BMD, so compare the gram per the square centimeters, not comparing the T-score, and I will show you some examples. And determine the significance. You have to understand the least significant change so that you understand that the BMD increase is really from the BMD that has increased, not from the technician or from the precision error. So this is a precision error. So each technologist, each machine have a little bit of precision error. So we should measure, or the technician, actually the DEXA tech should do 15 patients 3 times or 30 patients 2 times. They'll have the patients sit up and reposition every time and measure the % coefficient of variation. And these will calculate to the least significant change. Normally, we multiply by 2.77, which is the 95% confidence that the change is real. And for ISCD, they recommend that overall, the least significant change should not be above roughly 5%. If your technician have very high least significant change, then you should have them retrain and redo the least significant change. So what is the skeletal site that we use to monitor? For treatment of anti-resorptive agent, the lumbar spine is the most responsive to treatment and have the best precision. Next is the total hip, followed by the femoral neck. I have 2 examples of the follow-up cases. This is a 68-year-old lady in February 2016. She has a asymptomatic compression fracture of T10 to 11. And this is the BMD scan. The femoral neck BMD is minus 2.2, and the total hip BMD is minus 0.8. And here is the lumbar spine because the L3 and L4 have a lot of degenerative changes, so it was excluded. So L1 and L2 were used to calculate. So her BMD at L1 and L2 is minus 0.5. So after treatment with zoledronic acid for 2 years, the BMD scan has repeated. So now the femoral neck BMD is minus 2.1 and total hip is minus 0.7. She have a new fracture at L2. She have mild degree of compression fracture. And also a lot of degenerative change, and I don't know if you could see it clear here. She also have the aortic calcification. So her lumbar spine BMD is higher than her hip BMD. In this case, the least significant change of the femoral neck BMD is 0.008. So how do we compare between 2 BMD? This is the one in 2018, the new one, and this is 2016. When we compare, we use these numbers. So we use BMD in gram per square centimeter. So it's 0.582 minus the previous BMD and all divided by the previous one. So she has 0.014 gram per square meters improvement. And this is more than least significant change of 0.08. So in this case, we can interpret that she has significant improvement at the femoral neck site. However, in the lumbar spine, you can see here, the BMD in 2018, we left with only one vertebrae, so it's not available. We cannot use lumbar spine BMD for follow-up. And here is my last case, a 61-year-old female with 20 years of rheumatoid arthritis. She also have wrist fracture. She have a DEXA scan in 2019, and this is her BMD. At that time, L1 and L2 T-score is 0.076. T-score is minus 3.2. And it's very small here that at that time, because we follow the ISCD in our hospital back then, so we used the enhanced reference for T-score at that time. And this is her femoral neck BMD, minus 2.8 and minus 1.7. Again, the reference range, we use the enhanced, which is the US data back in 2019. So she was treated with alendronate, 7 milligram per week for 2 years, and there's a repeated DEXA scan here. For L1 and L2, the BMD T-score is minus 2.2. So only 2 years, her BMD has reached over 1.0 T-score improvement, which is more than we expected in patients receive anti-resorptive. And then for her hip BMD is also some improvement. Now, the least significant change, this is the technician in my hospital, the least significant change is quite wide. It's 0.042 for the lumbar spine and 0.078 in the femoral neck. So to compare these two BMDs, again, you cannot really use the T-score because the second scan, the reference range is Asian. So in Thailand, the reference range Asian is actually mean Japanese. So Japanese has a smaller body bone frame. So when the Thai, even the same number of BMD with Japanese reference, the T-score is automatically much better. So what you want to compare, you just want to compare the real numbers here for the BMD. So in this patient who received alendronate, 0.812 minus 0.776 here, and it's really a big improvement at 4.7% in 2 years. However, the least significant change is so high, 0.02. So to interpret this result, I have to say there's no significant change in this BMD scan. And when we look back why there's no significant change, the reason is because the least significant change is too wide, it's too big. We have to go back to our technician and have him or her retrain how to make the DEXA more accurately and have the least significant change. Again, in this case, I want to emphasize that always look at the reference range before you interpret the T-score. So in my last 20 seconds, I want to conclude about the BMD interpretation. This is the suggested from the IWG for interpret the BMD interpretation. So it's PAREDD, PARED. Position, artifacts, look at the region of interest, edge detection, demographics, and reference range. So use this PAREDD before you interpret the DEXA scan result. And for your monitoring, make sure you compare the same thing, the same machine, the same model, the same position, and you use the bone mineral density in the unit of gram per square meters, not the T-score for comparison, and understand the least significant change and how to interpret the improvement or the changes in the BMD. And this is where I work, and this is why our hospital logo looks like. And welcome you to come to visit Thailand sometime. Thank you.
Thank you. Our next distinguished speaker is Dr. Beena Hameed, consultant rheumatologist at King's College Hospital, Dubai Hills, Dubai, UAE. She'll be sharing her talk on a very important and practical topic, sequential therapies in osteoporosis. Please join me in welcoming Dr. Beena Hameed to the stage.
Thank you very much for the introduction, and thank you, Pakistan Society of Rheumatology organizers for the invite. So I'll be talking about sequential therapy in osteoporosis, which we are following in the recent years. Why? Because we have more choices, and the data has suggested they work differently, and if you sequence them correctly, you have a major improvement in the bone health. So I have no disclaimer. So we'll be looking at why sequential therapy is important in the management of osteoporosis. I will be discussing recent evidence and the guideline recommendations supporting sequential therapy in osteoporosis. So we know that osteoporosis is a silent disease. However, when the fracture happens, it can be quite devastating for the patient. So this data comes from 9 European countries and 14 organizations within, and it shows that 1 in 3 women and 1 in 5 men, 50 and above, would sustain a lifetime fragility fracture. So essentially it means then there is 8.9 million fractures happens a year, and it accounts for 1 fracture every 3 seconds. So when the fracture happens, only 20% of people would recover completely. 50% of them would have some disability, so there's a partial recovery. They lose independence. In particular, the functionality is limited in terms of such as taking steps. And 30% of them may die actually within a year of hip fracture. So this slide is for junior colleagues and for the medical students, because I think it's really important to understand how the bone dynamics work and how these medications produce their effect. So looking at the top right hand, you can see the major cells which are involved in the bone remodeling are your osteoblasts and your osteoclasts. Now, there are 2 important pathways that we have to understand. One is the rank ligand rank OPG pathway. The other one is the Wnt signaling pathway. So osteoblasts would increase, when they are active, they increase the expression of ranks receptors on the osteoclasts. And also they produce a protein called rank ligand. The interaction between the rank ligand and the rank would lead on to the increased proliferation and differentiation and function of the osteoclast, but then they lead on to the bone resorption. And then there's another protein produced by the osteoblast, it's called osteoprotogen or OPG, which would check this balance. So it would competitively bind the rank ligand and prevent its action to the rank, so you are looking at gaining bone, more bone. And the PTH, our normal hormone in our body, works on actually another pathway, which is a Wnt signaling pathway, which is an anabolic pathway. So there are some inhibitors produced by the osteoblast which would prevent the further bone formation. So PTH would actually inhibit those inhibitors and lead on to more bone formation. Now looking at the different drugs, I'll be only discussing those drugs which are involved in the sequencing the therapy in osteoporosis, not all of them. So the 2 important anti-resorptive are your bisphosphonate and denosumab. So starting with the bisphosphonate, which is our old friend, we've been using it for a long time, many years we've been using this, and the way it works is taken up by it binds to the hydroxyapatite, And this binding is so strong that it remains in the bones for a long period of time, even when you stop the medication. Now, the osteoclasts actually take up the bisphosphonates, and that causes the interference with their function, and it also leads on to the apoptosis of the cells, so the cells basically die. And there's also some animal studies suggesting that the bisphosphonate would also have some effect on the osteoblasts as well. And that's one of the reasons why they blunt some of the function of anabolic medications when they're given after bisphosphonate use. Now, talking of denosumab works in a different way. It basically acts at the rank and rank ligand pathway. It competitively inhibits the rank ligand to bind to rank. So you can understand it works at anti-resorptive. Of anabolic agents, your PTH analogs, of which we are very familiar with teriparatide, and I don't know that abaloparatide is coming soon in practice as well. So the PTH, the way it works, it has a direct effect on osteoblasts and leads on the proliferation, differentiation, increased number and functionality of the osteoblasts, and hence it causes the bone gain. It also helps to reabsorb the calcium and phosphate from the kidneys, and also calcium reabsorption from the intestines. Then the romosozumab, which is, I would say, relatively new. For the last few years, we've been using this, which is quite strong anabolic agent. It works through inhibition of the sclerostin. Now, sclerostin is produced by the osteocytes, which actually inhibit the Wnt pathway. Thereby, it actually prevents the osteoblast activation. However, by inhibiting the sclerostin, it is basically inhibiting, to some extent, inhibiting the osteoclast, but the major effect is on pre-osteoblasts, again, increasing their functionality, numbers, and also you would see some increase in the OPG and reduction in the rank ligand. So overall effect is anabolic activity. So these are the drugs that we use in sequencing. And if you look at the bone mineral density gain over 2 years, and of course 1 year for romosozumab, because we only used romosozumab for 1 year. So you could see in terms of bone mineral density gain in spine, the romosozumab and parathyroid hormone analog, and even denosumab, they are not different in terms of efficacy. When it comes to non-hip bone mineral density gain, you will see actually the more effective is IV zoledronic acid and denosumab. Looking at the fracture reduction at the spine level, you have your PTH analog, and it is almost equally effective for IV zoledronic acid and subcutaneous denosumab. And for non-spine fracture reduction, your IV zoledronic acid, subcutaneous denosumab, and PTH hormones, they overperform as compared to others. When you talk about cost effectiveness, so of course, biologics are very expensive. However, fracture reduction or fracture prevention comes highest with them. Whereas the HRT that we traditionally use in some of our patients, they're cheaper, but the fracture reduction is not great. But the bisphosphonates lie in the middle. So you have decent fracture reduction, and they also have help you to cost saving. So why sequential therapy? So certainly there would be scenarios where the patients are at a very high risk of fracturing. So you have urgency increasing the bone mineral density, because increasing the bone mineral density can be extrapolated into fracture reduction. So you want to use drugs which act fast. And these are which drugs? These are the anabolic agents. And we have also seen that the only drug which remains in the bones and have a continuous effect in maintaining the bone density fracture reduction is bisphosphonate, due to obvious reason. Whereas your denosumab and anabolics do not stay in the body longer. The moment you stop, the bone density declines. And particularly with denosumab, there's quite a steep fall in bone density and fracture of the bones. So certainly these drugs need a follow-on drugs. You have to give your patients some other medicine to maintain the bone density. And thirdly, it's really important to keep the sequence right. As we saw, some drugs can blunt the other's drug. So sequence could be anabolic to anti-resorptive, or reversal, anti-resorptive to anabolic, or anti-resorptive to anti-resorptive. So the first study is to look at anabolic teriparatide to anti-resorptive alendronate. So in this study, what they did, there were 4 arms to the study. They gave patients for 12 months parathyroid hormone, and they stopped, and then only continued the calcium and vitamin D. And that group is seen in red line. So you can clearly see that when you stop parathyroid and don't give anything, the red line is going down, means the bone density would reduce at both spine as well as hip level. However, when you switch parathyroid to alendronate, which is your blue line, you can see the bone density is maintained, and there's some gain at the hip level as well. They also looked at the combination of parathyroid to alendronate, but you can see it wasn't great. The combination of parathyroid to alendronate was same, actually, the way the alendronate is given whole period of the time. And you can say it's actually expensive combination, but the net effect is same as alendronate. And that is seen also in the bone turnover markers. You can see in both red line and the blue line, in the bone formation markers, there was rise. And then certainly the combination should have bone formation marker raised, but it's not showing the effect. And that's because of the fact they actually negate each effect, they actually blunt each other's effect. So this is the data from data switch study. Here we're looking at teriparatide to anti-resorptive denosumab switching. So here what they did was, for the first 24 months, patients were either given teriparatide and they switched to denosumab, or they were given denosumab to teriparatide, so reverse switching, or there was a combination therapy initially to denosumab. So looking at the blue line, the teriparatide to denosumab, which essentially means anabolic to anti-resorptive, you can see a credible increase in the bone density. What you gain, you are building on it. However, when you see the reversal of the switching, anti-resorptive to anabolic, you can see the red line actually dips down first. You see the bone loss, and then it starts rising, again because of the blunting effect of denosumab on teriparatide. Similarly, here you see the combination therapy actually working better. You can look at the green line, actually is going up, means this combination works better. So when you combine teriparatide to denosumab, this combination works better as compared to what we saw previous slide. The teriparatide to alendronate combination wasn't great. So now we're going to look at alendronate or denosumab when it switched to anabolic romosozumab or vice versa. This data comes from the 4 pivotal trials, the ARCH and the FRAME, where the romosozumab was given first, and then the patient had alendronate or denosumab. So just concentrate on the ARC study and the FRAME study. And then we look at on the 1-year gain in the bone mineral density, hip and the spine, which are seen on the solid green bars. So there was increase in bone mineral density. So essentially it means, again, if you switch from anabolic to anti-resorptive, you gain bone density. However, if you focus on the structure trial, where these patients actually had first anti-resorptive, alendronate or denosumab, and then they were given the romosozumab. So if you look at the orange bar, you see the bone mineral density wasn't great. The gain wasn't great. And the orange bar is missing on the second year because it wasn't included in that study. And then this is actually seen across the both sides. And the blue bar is where the denosumab was given first and they had romosozumab afterwards. And you can see certainly the bone mineral density gain was not so great first year. So but then there's a slow rise. By the second year, there was some bone mineral density gain. So it happens, but very slowly. And essentially then for that period of time, your patient is not protected for fracturing. So that's again the similar in terms of the bone turnover markers. So you can see the steep rise when the anabolics are given first in the bone formation markers, whereas when there's a reversal, you don't see that rise. So now we're looking at anti-resorptive to anti-resorptive. So for instance, your patient have been on denosumab, and due to some reason, you have to switch to alendronate. What happens? So the news is good. Here, 12 months of denosumab, and it was shifted to alendronate, there was maintenance of the bone density gain. So you can see the red line where patients actually received denosumab, and then when they were switched to alendronate, this bone density was maintained in all the important areas, and the same is translated into your bone resorption markers. So denosumab, as you know, is a strong anti-resorptive, so it led on to the suppression of the bone markers and was then maintained. So looking at the denosumab switch to zoledronic acid, now we know that zoledronic acid is also quite a powerful anti-resorptive therapy. So we'd expect probably the continuation or switching denosumab to zoledronic acid would be a good choice. However, in this study, what we saw that when after the 6 months of denosumab, patients were given zoledronic acid, actually there was fall in the bone mineral density. And that's again because of the negative effect on the remodeling process. And then in the study, they also gave some of the patient at 9 months later, thinking might be by 9 months, there would be some improvement in the remodeling. However, they didn't see the change. They also had a third arm where they saw if there is CTX, your bone resorption marker, is rising, then they gave zoledronic acid. However, that wasn't even successful. And the author then ended up saying maybe these are the patients you need a second zoledronic infusion 3 or 6 months later. There's actually another study. They also looked at what happens if the patients are given denosumab for few times then or for a longer period of time. Actually, they observed if the patient's been given longer period of time, denosumab, say 5-6 years, this effect is even more robust as compared to patients who would have like a few infusions and they are switched to zoledronic acid. They probably behave better. And that's again, this is another way of looking at when you give anti-resorptive bisphosphonate and you switch to denosumab, and when you compare it with anti-resorptive to anabolic romosozumab of teriparatide. So if you focus on bisphosphonate to romosozumab in red, so switching from bisphosphonate to romosozumab, the bone density measure is not only maintained, but also this further gain. And when you see the bisphosphonate to teriparatide group, which is in blue, you can see it wasn't very effective. And similarly, bisphosphonate to denosumab, one anti-resorptive to another anti-resorptive, again, there wasn't much improvement in bone density. So certainly this bisphosphonate to romosozumab stands out. Here actually they use a different bone resorption marker. So let's now look what is the recommendation says. So this is American Society of Bone and Mineral Research and Bone Health Osteoporosis Foundation task position in 2024. So what they advocate, if your patient is at imminent risk of fracture, for instance, if a patient has had a fracture within 2 years' time or even less than 2 years' time, and they have had a history of multiple fractures, then certainly these patients are very high risk. They should be given anabolic agents first before anti-resorptive. Similarly, if they have had a fracture 2 years or more than 2 years ago, but their bone density measurement shows that they do have current osteoporosis, they should be again anabolic first and then anti-resorptive. Again, this is American Association of Clinical Endocrinology Guidelines 2020. Again, they classify their patient into a very high risk, which means recent fracture less than 12, multiple fracture while being on therapy, use of drugs which cause skeletal harm, such as your steroids, but you can't stop them. And patients who had a very low bone density, T-score -3, FRAX calculation more than 4.5% in the hip or more than 30% in the major osteoporotic fracture risk, or they have a high fall risk, they are classified as very high risk fractures, and they certainly be on anabolic drugs first. So it essentially means that you should try and stratify your patient in terms of risk analysis and then only decide on treatment. So this is the Asia Pacific consensus on the long-term and sequential therapy for osteoporosis. And I like this slide because they give you a scenario-based advice. So what's saying if patient has a very high risk of fracture, certainly they should be on anabolic agents, romosozumab or teriparatide, or if not available or is cost an issue, you should go for stronger anti-resorptive such as IV bisphosphonate or denosumab. And if patient have new fractures or ongoing high risk, despite being on initial anti-resorptive therapy, you should be switching them to anabolics. And they're saying if someone sustains medication-related osteonecrosis of the jaw or atypical fracture following on to anti-resorptive, the next choice is teriparatide or SERMs. They also would advocate when you stop denosumab, don't leave them without medication, as they may end up having multiple fractures has been reported in the spine after stopping and steep fall in bone mineral density. So these patients need to be continued either on IV bisphosphonate or oral bisphosphonate or whatever is available. Any therapy is better than none. Similarly, completion of anabolic therapy should be followed on to bisphosphonate or SERMs. And the drug holidays is only applicable to bisphosphonates, as we saw before. And even these patients, when you think you have achieved the target, you can stop the medications, don't leave them alone. Make sure that you do the regular bone mineral density checks on them. If the risk of fracture rises, you restart the therapy. So take-home messages, your very high-risk patient need anabolic first, in particularly romosozumab, if it's available or if patients can afford. And anabolic medications that we know we can only give them for a limited period of time, they should be switched on to follow-on therapies. Denosumab, again, need bone maintenance therapy when you stop. Anabolic to anti-resorptive works better than the reverse. And if it's inevitable, reverse is inevitable, you give them romosozumab following bisphosphonate, which works better than giving teriparatide. And we saw the combination therapy of teriparatide and denosumab may give you additional benefit. However, when you combine teriparatide with lendronate, this combination doesn't offer you any further help. So that's all from me. Thank you.
Thank you, ma'am Beena.
For our next speaker, we are going to have Dr. Kamran Hameed, Associate Professor and Head of Department of Rheumatology at the Aga Khan Hospital, Dar es Salaam, Tanzania. Today, he will be speaking on an important and highly practical topic, steroid-induced osteoporosis, recent guidelines. Please everyone, join me in warmly welcoming Dr. Kamran Hameed to the stage.
Right, good morning everyone and Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Let me start. First, I'd like to thank the organizers for inviting me. It's always good to be back amongst friends and make new friends. And second, I would like to thank Dr. Beena for doing some of this spade work for me, because this presentation builds on what she has already talked about. You have a slide, advance it, click. Okay, I have no disclosures. This is Dar es Salaam, a port city of Tanzania, which is the commercial capital of the country. And this is where I've been working for the past 9 years. So the profile of this presentation is going to be disease burden and impact, which you have heard about. So I'll probably rush through them, some of these slides, pathogenesis, We'll look at the clinical trials available and try to get home some recommendations. So this we know, and Dr. Beena has already displayed how significant this condition is, and I'm going to take it a little further. And the task is glucocorticoid-induced osteoporosis. So just to give us some idea, there's an estimated 1.2% of general population is on glucocorticoids in the US. And one study from Korea suggested that 83% of patients with rheumatoid arthritis were receiving or had received glucocorticoid therapy. This data is not very different from what we see in our rheumatological diseases, and I think we have to be cognizant of these numbers. So moving on, I'd just like to point out one concept, which is DALYs, which is years of life lost and years lived with disability. This is something that is useful to determine the impact of diseases that cause significant morbidity and mortality. And keeping this concept in mind, these are the numbers that you would like to see. And look at the numbers per 100,000. In Germany, I wonder why these two countries are so high, but it's probably because of the demographics of the population having more elderly people than the young population. But as these are changing over time, we are likely to see much more disease in our elderly population. So what is the pathogenesis? And with the cost of repeating some of the things mentioned, I'd like to have a simplistic approach. So in simple terms, you have increased bone resorption or decreased bone formation. So the apple on the head just gives you that. If you wanted to go for a little more complex concept, there are many satellites in orbit. And like Dr. Beena has already mentioned, the two cells that are of significant origin and for our young doctors is mesenchymal stem cells and hemopoietic stem cells. Normally, the mesenchymal stem cells differentiate into osteoblasts, proosteoblasts, and then osteoblasts, and finally the osteocytes and the lining cells. Whereas the hemopoietic stem cells are progressively maturing into osteoclasts. So what does the steroid do? Glucocorticoid excess shifts the balance, and mesenchymal stem cells also selectively mature towards adipogenesis, that is fatty marrow or fatty deposits, rather than going into this pathway. The second cell that is influenced is the osteocyte, which has decreased proliferation under the influence of glucocorticoid and apoptosis or automated cell death. So this leads to decreased function of the osteocytes. On the other hand, the hemopoietic stem cells, there is accelerated transformation into osteoclastogenesis, and there is increased lifespan of the osteoclasts, obviously tilting the balance for bone resorption. If people in the audience are not satisfied with this complexity, we can go to a complicated one, which is this. And here we talk about the various pathways which were mentioned by Dr. Beena as well. But these are important because these are targets of current and future therapies. So what do? We look at the literature. Probably it's difficult for all of us to go through all that, so we leave it to the experts. And let's look at the main literature studies, main studies that have happened. There are 5 main studies which are of significance because of the number of patients that they recruited. And they all have compared a primary agent with either a placebo or a second agent. These are head-to-head comparisons. And these are the characteristics of the study population. But I'd just like to come to where the meat is. They all looked at bone density, and these were the landmarks they looked at. They measured T-scores at lumbar spine, and proportion of patients with prevalent vertebral fractures was between 14 to 37. So these studies are not homogeneous, so they cannot be compared as apples with apples. So we need to be aware of that. So other factors that they did not compare between these studies was supplementation with vitamin D and comorbidities. So what is the message from these studies? The message is that these are all showing superiority or non-inferiority to the medicines tested. That means everything that was tested showed that it does work to some extent or significant extent. The number of fractures in the study was small, so the final outcome that we are all looking for as clinicians is fracture reduction rate. But the studies were not powered to look at fracture reduction rate, they were more powered to look at the changes in bone density. So recommendations, the two important documents that I am using as reference is the ACR guidelines from 2022 and the Japanese Society for Bone and Mineral Research. So what is the recommendation by these initial screening? And these are simple messages, and we'll go to a little more complex discussion on that. And initial clinical fracture risk assessment should be done for anybody who is using glucocorticoid therapy more than 2.5 milligram a day for more than 3 months. But mind it that this is not necessarily current therapy. It is also people who have been recently on therapy for more than 6 months, more than 3 months. So it is important to do an initial assessment. We also are familiar with the FRAX calculator, which is very useful for people over the age of 40. With people less than 40, the FRAX has not been validated. We'll talk about that in a little while. So this is the recommendation for initial fracture risk reduction assessment. You do clinical assessment considering the endocrine issues, family history, pattern of previous fracture, etc. And you can classify these individuals into 3 main groups: children under 18, adults less than 40, and adults more than 40. So these are the presentations. This is where you make the decision, and these are treatment recommendations. The lighter one is not a strong indication, strong recommendation, whereas the dark ones are strong indicator recommendations. So in adults less than 40, do bone mineral density with vertebral fracture assessment, which we saw earlier from our first speaker, an X-ray as soon as possible after starting glucocorticoid therapy. And for people more than 40, you can also use the FRAX calculator, which is in our society where there are limited resources, which can actually bypass the need for BMD. And we'll talk about that in a while. So this is the FRAX calculator, which is available online. You can go on, put the data of your patients, and it will give you a score of major osteoporotic fracture risk for 10 years and hip fracture risk over the 10 years. The T-score is not mandatory, so if you don't have a patient's bone density, you can still use the FRAX score, and it will give you a calculated risk over 10 years. So according to FRAX, you will then be able to identify major osteoporotic fracture risk. If it is less than 10, we call it mild, moderate, and very high. This will help us decide how urgent and how significant the treatment requirement is. This is from the Japanese Society for Bone and Mineral Research, and I find it much more convenient, but you can use either way. Those are tests which do not require BMD. So what is the general guidance is health maintenance, vitamin D and calcium supplementation, weight-bearing exercises. You assess the clinical risk factors according to this table here. Prior fragility fracture, the score could be 0 or 1. And these are the 4 parameters you would look at, and this would require bone mineral density or compared with young adult males. And if the score is greater than 3, then you would start treatment. If the greater score is less than 3, then follow-up risk assessment is advised. This is a simplistic approach to how you can use this effectively. So initiation of therapy, there's a strong recommendation you treat with anti-osteoporotic therapy if people are more than 40 and at a high or a very high risk. Adults more than 40 years with very high risk fracture, conditionally recommend, and Dr. Beena talked about anabolic as an indicator for high risk individuals. And this is the table, the graph that shows the various categories. Low risk individuals, moderate risk individuals, high risk, and very high risk. And you can see even in the low risk or moderate risk, you divide by age, 40, less than 40 or more, and these are the recommendations that we need to start. Reassessment. Once you start, how frequently do you reassess? The recommendation is 1 to 2 years. For adults continuing chronic glucocorticoid therapy but less than 7.5 and assessed as low risk fracture, we strongly recommend fracture risk assessment every 1 to 2 years. And this is the table suggesting the pattern or the decision points here. Children less than 18, if they have back pain or clinically significant new fracture, reassess them after 2 years. So let's move on. What happens if we discontinue glucocorticoid therapy? So first is that once you identify the risk, start the therapy concomitantly. You don't wait for something to happen to start therapy. You start the therapy concomitantly. The second part is that you reassess periodically for those cases that we mentioned. And if the glucocorticoids is discontinued, what do we do as clinicians? So, if the risk is moderate, high, or very high, then even after discontinuation of glucocorticoid, you will continue the therapy. If adults taking anti-osteoporotic therapy and discontinued glucocorticoid, no new fractures, and density is more than minus 2.5 T-score, then strongly recommended to stop the anti-osteoporotic therapy. Right? But there are certain, Dr. Hameed also talked about the sequential therapy, and with certain agents it is recommended strongly to continue sequential therapy. Okay. And this is after initial therapy. So if somebody is on oral or IV bisphosphonates or raloxifene and the risk is low, you don't need to go for sequential therapy. But even if the density is higher than 2.5 and they are on any of these agents, it is advisable that conditional recommendation is to continue or change to a sequential therapy. For people who have very high risk, whatever the bone density, if it is less than minus 2.5 or a fragility fracture, continue the current therapy. You don't need to move to sequential therapy in this group. What happens in treatment failure? People are on treatment but still have had osteoporotic fracture within the 12 months post-therapy or had loss of bone bone density over the years. So it's recommended changing to another class of anti-osteoporotic therapy. And the next slide tells you what are the options. From bisphosphonates, you go on to these agents. You can go to IV bisphosphonates if they are on oral, but denosumab, parathormone, and derivatives are recommended. From raloxifene, you can move on to these agents. And these are recommendations for switching therapy if you come across failure of therapy. So what are the main take-homes? You screen patients proactively, preemptively, assess fracture risk, you use fracs as well. General measures, exercise, calcium, vitamin D supplementation, pharmacological therapy in very high and high risk, very high risk, consider anabolic agents. Moderate risk, conditional recommendation. Pharmacological therapy, less than 40 years, special populations, sequential therapy we talked about, and certain contraindications. So the final take home is glucocorticoid-induced osteoporosis is a significant condition with high impact. So the first and important thing is do no harm. Try and restrict the use of steroids, low dose as least for the least possible duration. Address underlying disease effectively. There are multiple points at which glucocorticoids affect bone metabolism. Preemptive approach to identify risk and initiate treatment is needed. Multiple agents have been proven to be efficacious, and reevaluation and risk modification is vital. So thank you for your attention. We'll wait for the question and answers.
Thank you so much, sir. Before beginning forward, I would like Professor Arif to please give a brief intro on fracture lesion.
That was a brilliant session. Thank you so much. Brilliant talks and a great audience on a Sunday morning. I would welcome Professor Shaheena, Asif, especially our teacher, our mentor, our colleague, our friend who's here right now. Madam, thank you for being here. Thank you so much. We have done this to introduce a fracture liaison service in each and every hospital. And that is the take-home message of this conference. So we'll have a panel discussion and question and answers there. But before that, I would like to introduce Professor Arif Khan, who is a fellow in spine surgery and who is a professor and HOD Department of Orthopedic and Spine Surgery. And he is at National Hospital, National Life Care Hospital. Okay. So basically, he's also in the Asia Pacific. You've done a lot of work for fracture liaison service.
I request our expert panels to please first come on the stage, and then we can have views from the chair. So please kindly announce all expert panels to come.
For our expert panel, we are now pleased to invite Professor Dr. Ahmed Saeed, convener and President of Pakistan Society of Rheumatology, co-chair of Arthritis Care Foundation and Head of Department of Rheumatology at Central Park Medical College, Lahore. He is joined by Professor M.A Wajid, Consultant Orthopedic Surgeon at National Hospital and Medical Center Postgraduate Institute, Lahore, and Professor Rizwan Akram, Consultant Orthopedic Surgeon at Gurki Trust Teaching Hospital, Lahore. Adding a multidisciplinary perspective, we are now honored to have Professor Shaheena Asif, Dean of Department of Obs and Gynae at LMDC College, Lahore. Also part of this distinguished panel, we have Professor Khalil Ahmed Gill, an eminent orthopedic surgeon, and Professor Rashid Saeed from Allama Iqbal Medical College and National Hospital Postgraduate Institute, Lahore. Completing this esteemed panel, we have Professor Zamir Ahmed Sumoro, Head of Department Orthopedic at Chandka Medical College, Larkana, and Professor Zulfikar Ali Sumoro, Principal Ghulam Medical College, Larkana, Sakhar, and Consultant Orthopedic Surgeon.
We would also like to welcome our esteemed speakers to please join the expert panelists on the stage as well. Thank you, everybody.
Thank you so much. Our panelists are right in front of us. I'll request Professor Arif, can you introduce the fracture liaison service as established in Pakistan currently?
Thank you very much, Professor Meed. First of all, I'm grateful to the organizers for inviting me and my other orthopedic colleagues. The burden of osteoporosis is enormous. I think we need to understand that this is an epidemic that we are facing, and we are closing our eyes on it. Every other second, somebody is having a fracture because of osteoporosis. Now, the focus is mainly on the fractures, but we are ignoring other areas as well. For example, the impact that it is having on elective orthopedic procedures like joint replacement and spine surgeries is also enormous. Then the impact on the quality of life, the freedom of movement, and the psychological impact also is enormous. Now, when the problem grows so much, then one specialty or one person cannot tackle it up. And the specialties that are involved here are physicians, rheumatologists, endocrinologists, orthopedic surgeons, rehabs, and administrative services. They're all important. And gynecologists. So unless we all join hands here, it's almost impossible to control this epidemic. And so far, in majority of the hospitals in Pakistan, we are working as individual specialties, and everybody is trying to tackle the problem on their own. In few hospitals, we have developed the fracture liaisons services. Somewhere it's very effective. In majority of the place, it's not as effective as it should be, and there's a room for improvement. But now through this platform, I think if this recommendation goes that every hospital should work on developing the fracture liaison services to improve the care of these fractures, this is one strong message that we can spread in the country. And then we need to have teams that involve all these specialties, and then we work strategies based on the resources available to us in every hospital. And then we can develop SOPs, we can develop information network, and we can reach to individual patients. So thank you very much. I think this is how we should open this discussion.
Thank you so much. Do we have time for the video, Ahmed? We could. There's Professor Tashfeen from AKU, who is the chair of Fracture Liaison Service. He is in USA right now, could not join us. So he has sent a little video. I think if we are going to improve the health and prevent fractures and prevent the morbidity and mortality which is associated with osteoporosis, especially when you have one fracture and it gets fixed and you don't follow up with and don't have a fracture liaison service in the hospital, patients get their fractures fixed and they leave the hospital and they come back again with another fracture. So this is what we want to avoid. So let's see, we will take 3 minutes of everybody's time to see what Tashfeen, who heads the fracture liaison service at AKU, has to say about it. Can I try?
Yeah.
Assalamu alaikum. My name is Tashfeen Ahmed, an orthopedic surgeon from Aga Khan University in Karachi. Welcome to this panel discussion on osteoporosis in the conference on global insights and local impact. I thank the organizers, especially Dr. M.A Wajid, for inviting me. I preside the Fragility Fracture Network in Pakistan, which works on osteoporosis. I have nothing to declare. And one of the questions that we want to address is, do we know the impact of osteoporosis? Now, we know that osteoporosis can cause hip fractures and vertebral fractures, and it commonly affects the elderly. And many of them don't regain the same mobility as before. Up to 30% of them die, in fact, within a year. And there is a rising incidence. In the rest of the world, by 2050, there will be double the number of fragility fractures, while in our region, South Asia, 6 times more fractures are expected. Now, should we change our practices when we expect so much increase? So, for the hip fractures and vertebral fractures, are we really screening them for osteoporosis? Are we treating them? Studies show that only 20% of the patients get screened and treated for osteoporosis. And the fact that the fragility of bone is separate and the frailty of the body is separate, and both need to be addressed, that is missing in our current management, which is known as the orthogeriatric approach. Now, how can we improve the care? The orthogeriatric approach implies multidisciplinary co-management, which means frailty of the body and addressing the comorbids, excellent rehabilitation in order to maximally regain the function and quality of life, as well as robust secondary prevention of fracture, which implies addressing the fragility of the bone as well as reducing the risk of fractures. Now, the studies show that once this approach is implemented, up to 50% reduction in mortality can be achieved. And the functional status, many of them who are unable to walk again, we can make them able to walk again if properly this approach is implemented. Now, who is responsible for this? All of these different specialists are treating osteoporosis at present. But what we particularly feel is deficient is the need for specialist support services. Physiotherapists, nutritionists, specialist nurses, they need special training to deal with these patients in order to get the best outcomes. And also there are different healthcare services across Pakistan, government, private, and many differences within each of them. So the different hospitals need to have a uniformity in the care that they provide to patients with osteoporosis and with the fractures resulting from it. So that means that we need to unite and we need to commit to the cause of improving care. So Mahathir Mohamad said, one day we will die, rest of the days we won't. That means that the quality of the life of whatever days of life are left, that needs to be the best as possible. So our mission of Fragility Fracture Network is to optimize globally the multidisciplinary management and including the secondary prevention guided by the 4 pillars of care. What are those? Acute care should be appropriate, rehabilitation, secondary prevention, and develop alliances. So that's what we are for. I invite all of you to join us, join the Fragility Fracture Network Pakistan, because we are calling to implement a systematic approach to fragility fracture care with the goal of restoring function and preventing subsequent fractures without further delay. With that, I hand over to the coordinators to continue with the panel discussion, and I hope this will be an enlightening session and which will motivate all of you to inshallah work on improving care and joining the Fragility Fracture Network. Thank you.
Thank you. I would like to ask a few questions from our expert panelists. There are 2 questions addressed to Dr. Sumapa from Dr. Bilal Azim Bhatt. First is that which machine measures NOF bone density better, hologic or G lunar?
What is the...
Which machine measures the osteoporosis better, hologic or G lunar?
Actually, both of them is standard. So you can use either GE Luna and hologic. It's just that you, when you monitor, when you use to follow up, you should use the same brand, particularly same machine.
So no one is better. Another question is,
both are good, nothing better, equally.
Equally. Can we take help from AI in reducing the least significant change or removing human error in DEXA?
Can you ask?
Can we use AI, artificial intelligence, in reducing the least significant error while interpreting?
For the AI program now, they're looking at the plain film. So even just when patient come with hip fracture, you will do the X-ray anyway. So from the plain film, they're developing some AI program that you can use to see the bone quality as well as the bone mineral density. So there's something toward moving to the AI for the not only the DEXA but also just the plain films to see if they have any osteoporosis. And what is the question about least significant change? Chairman, I'm sorry, what is the question about least significant change?
Can you use AI, artificial intelligence?
So the least significant change, you need to have your technician to repeat the measurement and calculate the least significant change. So for the AI, probably not for the least significant change.
Now we go to our goal, and I'll ask each panelist, we'll give them 1 minute each because of the shortage of time, how to establish, what do they think? How do we establish a fracture liaison service in the hospitals? Dr. Arif, can you start with that? Because
yes. So I think first we need to understand the importance of it. Do we really need it or not? And that we have discussed, and now everybody should be convinced that we need fracture liaison services to be established in every teaching hospital at least, and then we can go to the district levels as well. So now that we understand the importance of it, we need to gather. And who are the specialties involved? These include the physician, the rheumatologist, endocrinologist, geriatricians, orthopedic surgeons, rehab nurses, OBG, and administration. And we need to have a discussion on this and develop SOPs. Now, these facilities in every hospital would be different. And therefore, we need to understand how can we develop according to our own resources. So I think every panelist can give their opinion based on their experiences and their resources, and maybe at the end we can summarize on how to proceed forward.
Yes, who would like to volunteer from the panelists?
So I would like Professor Shaheena Asif to give her input that every 1 out of 3 women is going to fracture in any case after the age of 50. So Professor Shaheena is an eminent leader in the gynae obstetrics. Professor Shaheena Asif, starting.
Thank you. Thank you very much for asking me to come to this panel. To tell you honestly, my knowledge of rheumatology and orthopedics is very, very little, and I'm only here to look pretty. The thing about women is, the thing about women that I have noticed in my practice is that there is a great decline of bone health, not in the older women as we used to assume that it is due to lack of estrogens. The bone health in our younger generation, the young girls that I see, is very poor. And it's because of their eating habits and their sleeping habits and their habits of exercise and physical activity. So the girls are more at risk. The older women, when they are on their menopause and their lack of estrogen is a big threat to them. So my message to all the women always is that they have to look after themselves as a whole and not look at one thing alone. Osteoporosis is a part of a process that they've been through all their lives. And then when estrogen takes its toll and we are lacking estrogen, then we are more prone to fractures. I'm one of those people who is accident prone, and Dr. Rizwan here will bear me out. I have broken every single bone in my body. I've broken my nose, I've broken my clavicle, I've broken my elbows, I've broken my right shoulder in 7 places and my left shoulder in 3 places. They've always been there to look after me.
Madam,
but it's never been due to osteoporosis.
Madam, did they
I am
your DEXA
accident prone. I've had a head injury, I've broken the upper jaw.
But this is the burning question.
Near-death experiences.
Professor
But
Shaheena, so the
yes,
question is,
I think my weight did protect me. I wasn't that frail, and for once I, feel that looking after an older person is much more difficult when your estrogens are lacking. But then if you're accident prone like me, you keep having your falls all throughout your life. So you need to look at your ears, you look at your spine, and it's not the estrogen alone that makes us fall. I don't have a lot to say about rheumatology, and I'd leave it to the experts.
Yes.
I come from Dr. Zulfikar from Sakhar. I am orthopedic surgeon, and I attended most of the cases in orthopedic OPDs because of depend upon the quality of the film, the osteoporosis or the osteo, and it is to advise the DEXA or other BMD. My suggestion is that because of there is the osteoporosis is the metabolic bone disorder disease. It associated with the hyperparathyroidism, rickets in children, osteomalacia in adult. If your diagnosis on quality of the film is osteoporosis, should be advised to all the investigation, then to treat with a fracture or without fracture. Thank you.
I just want to remind everyone that we are short of time. So the question from us to the panelist is, how do we do a fracture liaison? One person has to come up with one. Dr. Rizwan, you want to tell us? Or Dr. Rashid? Yeah. Because with fragility fractures, frequent falls, one fracture, then there's going to be a multiple fractures. So what do we do? We have 2 minutes to, yeah.
Thank you very much. First of all, I congratulate the Society of Rheumatologists for such a wonderful conduction of this conference, and thank you for the invite. I think I agree with Professor Shaheena Asif that we should educate our younger generation for improving their diet and exercise, and they should be more active. So that I think the prevention is the best course of treatment. We usually see fracture, neck of femur, radius or spine. I think once a patient has a fracture, his lifestyle is totally changed, his morbidity increases. So I think it's better to prevent, and there are certain medication, their lifestyle changing, there are drugs which can be stopped, and the other eating habits. I think that is what I want to convey, that prevention is better than the treatment.
Thank you, M.A Rizwan. I think if we need to here to focus on developing the liaison services.
Exactly.
Yeah.
I will not take more time. Actually, we have to have an action plan for starting something. We know the problem, we know the burden. First thing I propose that we should make one working group on osteoporosis, taking care of prevention of fractures, and other is liaison committee on fractures. These should be two groups, prevention and a fracture liaison committee. And I think being a part of an orthopedic community, we should nominate few people who may start the program along with the person nominated from Society of Rheumatology and Society of Endocrinology. And we should decide a timeline in which that core group will make certain points clear and an action plan to how to start it on a national level as well as in a institutional levels.
Yes.
So this is the right time. So we have to start it like this.
Excellent, Rizwan.
So
Wajid, would you like to add to it?
You are having a next orthocon.
Yes.
Sir? Yes, why not, sir?
No, what he suggested that there should be one central committee from all these associations, and then they should develop the recommendations which should be implemented by the individual hospital committees. This is a reasonable suggestion. Wajid?
Thank you. In April, we are having orthocon under your leadership.
Yes.
So we can make a timeline that till that time, we should have all the points clear.
Thank you very much. I'm honored to be invited. Thank you for having me. I think we all live in this country. We know how this country works. The question is it a top-down or bottom-up? And there is a living example in this conference that you can talk all day, but how did rheumatology start in this country or in this city? It is bottom-up. You can sit and make committees and meet as many times as you want. Nothing will happen. How did rheumatology start? It's in our living memory that one person and associate with other, they started that. It's the same environment. It's the same initiative. If we want to do it, it has to be bottom up. We have to create a nidus and then it will grow. Otherwise, you can have national guidelines. They are all pieces of paper. There are already so many. And it will not work. And the point comes, who will do it? When it comes to who will do it, everybody disappears.
So we have Rizwan who's already said he will do it. So let's talk about this.
Has shown it that how the rheumatology started. It was just one simple nidus and it has grown over time. And that is a living example. So any new initiative in this, in my view, in this country has to follow that, and eventually it will grow over 20 years time.
Okay.
Good enough. Professor Khalil?
I will add only one thing. By the together. We should, make focal persons in various regions so that they would be coordinating with the central body. And that will make sure with, treatment of patients with all institutions in that area. And they will, try to, it's not only saying operation. we have to manage the things, the implants. Some patients are needy, some are, kind of well off. So he has to work for all those patients who are presenting with the fragility fractures.
So let me sum it up. We'll make a committee with focal persons and we'll deliberate on it and we'll get back, and who are the members of that committee, we'll decide and pass it on. And I think we are running short of time.
So we have Dr. Zulfikar Ali Somro, so we would like to have a...
Only about fracture liaison.
Thank you.
Fracture liaison only.
I do endorse the idea of Dr. Rizwan, and we need to have a good integration with society level of the Rheumatology Society, POA Pakistan Orthopedic Association, and especially when we are talking about the care of the fragility fractures, especially at the tertiary level hospitals, and we have to develop the integrated model. So I can quote that Trauma Center, SUIT, NICVD, they are settling the satellite center in the different districts, and they are working in coordination for better care individually, and especially Trauma Center have established different satellite center in interior Sindh, and they have started the coordinated efforts for developing the fracture care early. So they are setting the satellite centers and they are working in a coordination that they can be fixed early and get mobilization. Thank you.
That's great. So one other thing, because we are now at this podium, I'm just standing here and I'm asking all of you, yes, to set up at least requesting secondary prevention services whenever you people see somebody who has already fractured. So do refer that patient to an endocrine, a rheumatology colleague who has special interest in osteoporosis, and get a DEXA scan and let that colleague decide what kind of medication that person, lady or person has to be on. And there is one more thing which I would like to highlight. Apart from secondary prevention, there is quaternary prevention as well. Anyone in the hall can tell me about quaternary prevention, what exactly it means. Because we know primary, so we have been talking about it. So quaternary prevention, unfortunately, is over medication, which our patients are having. Without having a baseline DEXA, a 45-year-old with OA is getting bisphosphonate and getting an atypical fracture. So that kind of over-medication is also something which needs to be discouraged. I think Professor Nikhat would now sum up and conclude the session.
We should not miss a fracture. The fracture has to go to an endocrinologist or a rheumatologist. We should prevent falls, healthy food, exercise, and get together to form fracture liaison service. I have Senator Dr. Zarka here, I can see. Dr. Zarka, welcome. You are our representative. So you know how women are suffering from arthritis and osteoporosis. So I think we need to talk to the health committees at the parliament level. Thank you so much everyone for your patient listening, for the panelists, for the speakers. Excellent and brilliant talks and a brilliant discussion, but this time it should be fruitful and we should have a fracture liaison service so that person who fractures never fractures again. Thank you so much.
जी जी बोलूं जी इधर आ जाओ अच्छा जी थैंक यू कैन आई जस्ट थैंक यू डॉक्टर निगहत अस्सलाम वालेकुम जी आई एक्चुअली वांटेड टू से समथिंग नॉट हैव अ फोटो बट थैंक यू
Sorry, Zarka is many years junior to me. So she was our baby at college also. And now, mashallah, she's a member of the parliament. And so we just need a voice from there to help us set up this liaison.
Thank you. So I'd just like to say, while Nikhat is coming to stand, that it's a privilege to be here, and I'm so delighted that the Pakistan Society for Rheumatology is such a success story, and the Arthritis Care Foundation sets such a beautiful example for doctors all over Pakistan. Because once the photo is done, So I just like to say thank you very much for including me in this. And I am a member of the Senate of Pakistan. I'm from Lahore, so I represent Lahore and I represent doctors as well. And I am currently raising issues in the Health Committee. So if there's any issue that the rheumatologist or doctors in general want to raise about fair play amongst doctors, and the topic that I'm most keen about is ethics in medical practice. That is a topic we have forgotten all over Pakistan. We need to remember that again. Thank you so much.
Thank you, sir.
Thank you so much, everyone. Since we are running really short on time, I would request the worthy chairs, Professor Nigat Mir Ahmed, Professor Arif Khan and Dr. Saira Khan, to present a token of appreciation to our speakers. I would request the worthy chairs, Professor Nigat Mir Ahmed, Professor Arif Khan and Dr. Saira Khan, to present a token of appreciation to our speakers. First of all, I would like to invite our first speaker, Dr. Sumapa Chaiamnuay, to get a token of appreciation. Next up, Dr. Beena Hameed. And lastly, Dr. Kamran Hameed. Now I would like to request Professor Nigat Mir, Professor Sumaira Farman Raja and Professor M.A Saeed to present a token of appreciation to the chairs of the session. Professor Nigat Mir Ahmed. Professor Arif Khan. And Dr. Saira Khan. With this, we conclude this session. Thank you so much, everybody. And there is also a parallel session going on in Crystal Hall A with 3 talks as well.